Everyone. Today we'll discuss about syncope. So, what is syncope? Syncope is like a transient loss of consciousness where you have decreased cerebral perfusion. So that causes syncope per se. So syncope can be due to a cardiac condition. Sometimes it can be neural syncope. Sometimes it's due to postural hypertension. So before going into the details and all, we'll discuss about a case-based approach so that I'll understand better what is syncope. Then we'll discuss about how do you evaluate it and all. A 30-year-old female with a history of anxiety boarded in flight and has been found to be lost in consciousness and spontaneously recovered in few minutes. So she has an anxiety. So she boarded flight for the first time, or sometime maybe she is not used to that flight. So she was found unconsciousness. She was found in unconscious, but spontaneously recovered conscious within few minutes. So what is important in this, the patients, maybe the patient had some kind of panic attack or something. So patient who are hyperventilating, who have hypocarbia or something, hypocarbia itself can constrict the cerebral vessels, so it can decrease the perfusion in the brain. So this is important that this patient has some panic attack for which there is that cause hypocarbia can cause decreased cerebral perfusion by constricting the cerebral vessels, that can cause syncope. So this is one cause which I have seen. So that can be a cause where the syncope is caused by some panic attack which can cause respiratory alkalosis that can trigger the cerebral vasoconstriction. So this is such case. And 36-year-old male complaining of loss of conscious like episodic, which like episodes especially when he's passing urine or coughing. So this is like when passing urine or coughing, he's complaining of loss of conscious like episode. So he's complaining of syncopal episode especially when he's passing urine or cough. So this is an example of a neural syncope, neural mediated syncope. So most of the syncopes, especially in younger people who are less than 50 or 60 years, especially 45, 50 years, less than 40, younger people generally, this are most of the syncopes are neural mediated syncopes. so so neural mediated syncopes, how they affect, what generally happens is, I'll give you a brief pathophysiology behind how syncope is occurring. Generally what will happen is, whenever there is like when you're standing or something, let's say when you're standing, so there is decreased venous return. So this is censored by the carotid baroreceptors. So these carotid baroreceptors decrease the sensing pressure. It will stimulate the sympathetic pathway and decrease the vagal pathway. So what is problem in them is, so these people who are having neural syncope or something, so this pathway is affected. That can be a defect in the efferent pathway where it is sensing the signal the patient has low blood pressure, or efferent pathway where there is excessive activation of vagal pathway, or decreased activation of sympathetic flow. So there can be a problem anywhere. So that can cause the symptomatology of a syncope like loss of consciousness included because of the decreased perfusion, because the cardiac output is decreased, there is decreased perfusion. So here when the patient is coughing or something, there is some amount of afferent pathways, like they're all stimulate the vagus and all, that can stimulate the vagal nerve excessive stimulation, that can go into bradycardia, hypotension. So that can cause vagal syncope, especially mixation also can send an efferent to cause excessive vagal stimulation and all, that can cause vagal syncope. And also when you have a you press so highly on the carotid baroreceptor, when you examine the carotid, they always tell you don't press on the both sides at once. So because if you apply excessive pressure on the carotid baroreceptor, that can stimulate a vagal stimulation and can cause vagal syncope. So that is it. The problem can be at the efferent pathway, the problem can be the efferent pathway that can stimulate excessive vagal stimulation or decrease the sympathetic flow. So that can be any cause. These are all neural mediated syncopes. They are all mostly vagal syncopes where sometimes at micturition, sometimes on defecation, sometimes on sneezing, sometimes on coughing. So there can be a number of triggers, like some GE related complaints, sometimes when vomiting, sometimes when passing stool also they can have a syncope. So there can be a number of causes that can stimulate the vagal nerve that can cause syncope like symptoms. So always look for the trigger, what is the cause, that you can always expect some kind of trigger. Sometimes excessive fear, like when you're in panic or excessive fear, or when you're going for an tension or something, it will stimulate the vagal nerve and decrease the sympathetic flow, so that can present as a syncope also. These are all neural mediated syncopes. So always some kind of trigger is there, some amount of trigger is there, that can always find the trigger. Generally what is there is, if there is a trigger in them, I try to avoid the trigger. So and also that can, one more thing that can do is, first try to avoid the trigger. Wherever the trigger is there, try to avoid the trigger, and also any postural changes that can be done at that time you can done. And also most of them are supportive management, like consume enough amount of fluids, because that is mostly because mostly the final pathway is always due to the decreased perfusion. So you maintain adequate volume in the body. So and also if there are any offending drugs that can cause postural hypertension, that should be avoided. So and also you can actually, if still the non-pharmacological you are not able to maintain, you can try some drugs like fludrocortisone or metodrine. Some drugs can be tried in them. So that is how you treat these cases. You avoid the trigger if it is possible. If it is not possible, you adequately hydrate the patient. It also tell them that it is normal. Generally these are benign. They are not some emergency, some critical condition where you need to go for treatment definitively. So they generally benign conditions. So they generally might not have significant mortality risk also. They are like hardly less than 0.5% have a significant mortality risk, but generally benign, they might not reoccur also sometimes. So always supportive care. You avoid the trigger sometimes. If it is some kind of fear or something, try to avoid such situation where you feel fear or something. If it is something related to if there is particular posture that is causing you syncope like attacks, you try to avoid that posture or something. And also when you are about to get this syncope, like especially one more thing, there is that muscle strength tensing exercise like abdominal tensing and also crossing your leg, that can also prevent syncope like attacks when you are about to get it. You will feel some kind of diaphoresis like symptom when you are about to get syncope like attacks, especially in neural mediated syncope. So when you are getting such kind of attacks, you cross your legs or tense your abdominal muscles, that will be very helpful. That decreases syncope attack like almost like 40%. So you adequately hydrate, you avoid the trigger, you do tensing exercise like abdominal tensing or muscle tensing or cross your legs, so that you get adequate perfusion into the body, so that you'll get adequate perfusion is reached. And also if that is not managed, we can always try pharmacological agents like fludrocortisone or metodrine, and alpha agonists can be tried. There are many drugs that can be used. So this is case of neural mediated syncope. A 24-year-old male who was athlete started training recently for a competition, developed syncope after exertion for few minutes. So what is this? So a 24-year-old male definitely is exercising. Previously, he doesn't have any syncope attacks. Now presented with syncope-like attack after exerting for few minutes. So what is the cause? So after exerting for some time, he is developing syncope-like attacks. Mostly, you should always think for like first thing you'll ask if there is any specific trigger or not. Sometimes neural mediated syncopes can be a possibility. That also you'll ask for any whether he's hydrated well or not, whether he's properly taking fluids before going for exercise, because dehydration can itself present as syncope-like attacks. First, these common reasons should be always done. General neural mediated syncopes, you'll have a specific, like before trigger also will be there. So but sometimes exertion can also be a trigger for syncope. So that is first, dehydration should be checked for, and also you should always check for if there is any other previous history and any specific triggers are there other than exertion. And next thing you should always look for in the case of them is always get a baseline ECG, and also if possible get a echo also. So especially in athletes, when they are having when athletes request high amount of perfusion to the muscles and also to the brain. So sometimes when you are exerting on, you need to increase the perfusion, but this patient classically developed syncope after exerting for few minutes. So that means there is a demand mismatch. There is decreased perfusion after few minutes. That is why he is developing syncope. So first thing you need to suspect with hypertrophic obstructive cardiomyopathy, especially in these cases where they classically don't have any symptoms till then, but when they started exercising or they're doing their exerting them, or they develop classical syncope-like attacks, especially aortic stenosis or HOCM, they can present classical like syncope-like attack. This might be a case, especially in young people. Always age is unlikely in young people. So this is a case of HOCM where they will have no other symptoms. Generally, they have only exercise intolerance and also syncope-like attacks. Sometimes in severe cases, anginal symptoms might be there. But this might be a first presentation of HOCM. Get a 2D echo. You can ask for dynamic. You do dynamic testing. You will find a murmur. So that is all very important, and also this is due to the decreased perfusion. The patient was not able to compensate the perfusion for which he is doing exercising. So this is a case of HOCM. A 70-year-old female felt funny in the chest and complained of blackout-like episode and spontaneously recovered. So this is a case of like 70-year-old female who felt funny. The fun is generally what we feel is generally sometimes any fibrillation, sometimes they tell like palpitation. They clearly won't tell it is a palpitation. Like sometimes they'll tell I'm feeling uneasy. Something is going on in my heart or chest. They say sometimes palpitations might be like they sometimes can tell us palpitation. Sometimes they can tell us like I'm feeling funny like sensation or something is beating in the heart or something, and suddenly clamp out. So always in elderly people, always generally like I told you, in younger people generally neural cause syncopes are more common, whereas in elderly always cardiac symptoms and orthostatic hypotension always need to be ruled out before going into the before labeling it as some neural mediated syncope. So this might be a case of atrial fibrillation or some arrhythmia that is causing a syncope-like attack. So these are causes. Even ischemic heart disease where the decreased ejection fraction is also there, that can also cause syncope-like attack. So any structural heart disease or any AS, some kind of any arrhythmia can cause syncope-like attacks. One more thing is the patient is on some similar drugs. Orthostatic hypotension might itself can present a syncope-like attack. So if the patient recently started on alpha blockers or some some AC inhibitors or ARB inhibitors, which are prone to have significant first dose or orthostatic hypertension, they can develop orthostatic hypertension. That can also be a presentation of syncope. But this patient telling funny inches, this might be some kind of atrial fibrillation that can be presenting symptom of some syncope or something. This might be a arrhythmia or some structural heart disease that is causing syncope-like attack. So a 50-year-old male has disturbances of sleep pattern in the last 10 years, has rigidity-like symptoms and developed postural hypertension. And this patient has postural hypertension. This patient is, even postural hypertension can also present as a syncope-like attacks. So when the patient is having postural hypertension, especially but I'll go into the symptomatology. He's having sleep disturbance in the last 10 years. So, and also has rigidity-like symptoms and developed postural hypotension. So this is a case of so if you go on this is little complex, but he's having sleep disturbances, maybe posterior REM sleep disturbance. I need to have kept that discussion history more better. But sleep disturbances in the last 10 years, that there's REM sleep disturbances with along with rigidity-like symptoms. So this is extra Parkinson's disorder, mostly multiple system atrophy, where MSA and Parkinson's are the one things where they have REM sleep disturbances and autonomic involvement more. So generally these are Parkinson's and multiple system atrophy, which is an extra Parkinsonian disorder. They have like the rigidity, slow walking, they will all have that, especially, and they have associated sleep disturbances also. When you ask, the sleep disturbances are the first to start. REM behavioral disorders are the first to start initial symptom, then they develop rigidity and all muscle symptoms, and like motor symptoms are the one later to start. Early in their course only, first initial symptoms is, if you ask them, go back and ask any Parkinson's patient or any LMSA, generally you might be able to find some cases with REM behavioral disorders and all. So this might be a case of multi-system atrophy with rigidity, with, or maybe Parkinson's also, based on the what are the other features, how rapidly it progresses, you can tell whether it's MSA or not. But postural hypertension, this might be MSA with REM sleep disturbances and also postural hypertension that is due to the autonomic failure. So these are the combinations. There might be Parkinson's and MSCs, extra Parkinson's, some antipsychotic use. They can all have some autonomic disturbances that can cause syncope-like attacks. A 70-year-old male recently a case of diagnosed developed blackout-like attacks. So he was recently diagnosed with diabetes and he is developing blackout-like attacks. So this is 70-year-old male recently diagnosed with diabetes, but is now developing blackout-like attacks. Generally in elderly male, first I told you, any patient who is developing blackout-like attacks should always look out cardiac cause. So any structural heart disease is there, any valvular region is there, any arrhythmia is there, you can do Holter study, you can do 2D echo, you can do baseline ECG, you can get a carotid artery Doppler to roll out any decreased atherosclerotic change, increased atherosclerotic strength in the carotid artery, and also you can also check for these are the common causes. First you should look at the cardiac cause, and orthostatic have any dehydration is there, any recent drug use is there. So next you go, the patient is in case of diabetes. So diabetes itself can cause autonomic failure. So one of the early symptoms of a diabetic autonomic neuropathy in male is especially erectile dysfunction. So this might be a case of diabetes related autonomic failure. And also one more possibility is, especially in elderly, they might have some amount of amyloidosis is one problem that is seen in elderly. So amyloidosis can also cause autonomic failure. So there are a number of causes that can cause postural hypertension that related to autonomic failure. So that one, diabetes is a possibility. Any polyneuropathy per se, that can be diabetes related or some other vasculitic polyneuropathy. Amyloidosis can cause autonomic failure. So there is a hereditary condition where the autonomic failure is there. So they can all present as syncope because of the autonomic failure. So always ask for autonomic failure. Always any patient that comes to you to the OPD with a complaint of syncope, always check for the postural BP. So any change in the postural BP, so any change in the declining position, after 3 minutes you check more than 20 in the systolic, more than 10 in the diastolic after 3 minutes. So orthostatic hypertension is also early if it is less than 15 seconds, delayed more than 3 minutes. Generally it occurs between 0 to 3 minutes. If it is occurring within 15 seconds, it is early orthostatic hypertension. More than 3 minutes, it is delayed orthostatic hypertension. And most of these patients also who are having orthostatic hypertension will have supine hypertension, because of the excess stimulation at the supine levels, they have supine hypertension also. So that is one more thing I want to highlight. This might be a case of orthostatic hypertension where the postural dizziness is complained, but might be due to diabetes or some polyneuropathy, or some amyloidosis might be also be present. If there is other associated kidney failure or something, if there is renal failure, definitely you should suspect amyloidosis also. A 60-year-old male with a history of injury to spinal cord admitted with the complaints of bladder syndrome and has syncope-like attacks. So this is one more thing, like a 60-year-old male, a female with a history of injury to spinal cord. He has some kind of injury to spinal cord with bladder syndrome. There is bladder involvement definitely. So bladder is controlled by mostly autonomic pathway. So she has now syncope-like attacks. So what is the cause of syncope-like attacks? So generally, you know the autonomic medium, we know the vagal mediated and all, but spinal cord also has some autonomic pathway going on. It's going on in the in the spinal cord level. So if there is a spinal cord injury, that might cause autonomic can cause autonomic nerves damage, which is present in the spinal cord. So they can have a syncope like attacks also. So any spinal cord injury or cervical cord, especially cervical cord compressive myelopathy, they can also present with autonomic failure like symptoms. Because of the autonomic failure, there might be postural hypertension that can present as syncope like attacks. Especially with spinal cord injury is there, that might be autonomic failure that can present as syncope like attacks. That is a cause because of the postural hypertension and all. Then you can test for the postural hypertension. Any postural tachycardia is there, you check for there are different autonomic testing you can do. I'll tell you about the autonomic testing you do in these cases. But right now, this is the possibility. The autonomic failure is also a possibility in the case of spinal cord injuries. A 34-year-old male on his way to the cocktail party wore a bow tie and also buttoned up short shirt all till top, developed transient loss of consciousness like attacks. So this is one more thing I'll give you exam, especially when you're examining a case in the ward. You press carotid artery for the pulse and also to feel the pulse. Always they'll tell you don't press on the both side, don't press too hard, because sometimes when you excessively stimulate the carotid artery, it will stimulate the baroreceptors and can cause syncope like attacks. So this is exactly the same thing in the cocktail party. If you're wearing a tight shirts, tight neck collar shirts, or some bow tie, if you're tying it tightly, that can compress the carotid baroreceptor and can present as the syncope like it. This actually happens if you are wearing a tight shirts. So these are the various causes we all discussed about syncope. Neural mediated, as I said, vasovagal syncope, like in the case of provoked fear, anxiety, any intense emotion, or sight of blood. Some, especially in the exams, or some patient get this I'm feeling loss of consciousness when I see blood or something. These are all vasovagal syncope because excess to stimulation and all, excess to like any fear or something. So these are situational reflex syndrome. These are situational because of they can stimulate the efferent pathway, they can stimulate excessive vagal or decrease the sympathetic pathway by pulmonary while coughing, or some weight lifting, some any sneeze, any while instrumentation also. When you're intubating the patient also, that will excessively stimulate the vagal pathway, that can cause bronchospasm and syncope like attack also. And urogenital post-micturational or any you're instrumenting, that can stimulate the vagal nerve and that can cause syncope like attack. And gastrointestinal also, when you're swallowing, or sometimes any esophageal stimulation while endoscopy is being done. So rectal examination they can all trigger the vagal pathway. So generally, if they stimulate more vagal pathway, you'll find do more bradycardia and all. So that is bradycardia and associated hypotension is seen in the vagal syncope. Sometimes the vagal pathway might be normal. There is excessive, like when it is needed, sympathetic is not excessively stimulated. So generally, if you need a sympathetic stimulation, especially when you are standing up, you need to have sympathetic stimulation more so that the venous return increases. So if it is not there, sympathetic pathway is not stimulated also, it will present as syncope only. So Bajaj-Jari reflex is this very interesting concept where in the case of when there is decreased venous return, carotid baroreceptor will stimulate the sympathetic flux. Sympathetic pathway will cause increased ventricular contraction. So this might trigger the vagal pathway, so that can call Bajaj-Jari. Read about Bajaj-Jari reflex, that can also cause syncope-like symptoms. Carotid sinus sensitivity, we discussed carotid sinus major, ocular pressure sometimes, that can also present as syncope. Like ocular pressure also can present as syncope. So these are all the mechanisms that can cause neural mediated orthostatic hypertension, especially synuclein, Parkinson's disease, Lewy body disease, multisystem atrophy that we discussed in this case, and also secondary to diabetes or hereditary amyloidosis or any amyloidosis, hereditary sensory autonomic neuropathy. This presented very young age where sensory symptoms and autonomics are present, and autonomic neuropathy. Sjogren's can present it. Sjogren's is one condition that can present autonomic neuropathy. And HIV neuropathy is paraneoplasm, postprandial hypertension because of the sometimes after eating. This is one example we see. After eating, some people will feel dizzy because most of the circulation goes into the mesenteric circulation. So after eating, for some time the patient will feel dizzy. So you think this might be some kind of dumping syndrome, some kind of hypoglycemia, why the patient is feeling dizzy, or he just ate no hypoglycemia, sugars are normal. So that might be a possibility where that postprandial hypertension is mostly due to this, because of that most of the perfusion is going to the mesenteric artery. So there is decreased blood in the peripheral circulation. Volume depletion, iotrogenic is all. Any arrhythmia, sinus node dysfunction, AV block, supraventricular, any arrhythmia can present as cardiac syncope. Valvular, myocardic, obstructive, which we discussed HOCM. Atrial myxoma can also present with syncope. And effusion and tamponade, because of the perfusion, they can all present with a syncope also. Okay. So this is example possible So generally what we do is in neurological cases, most of them we manage mostly with the conservative management with proper fluid replacement and also abdominal tensing or crossing episodes and all. And where you can cross the leg so that venous return increases. Orthostatic hypotension also, if there is an offending drug that can cause ortho, you stop that drug, or else you properly salt and fluid replacement if still required fludrocortisone and midodrine can be tried. And also this is the how do you differentiate orthostatic hypotension and a neural mediated hypertension? Generally all neural mediated hypertension vagal, this vasovagal will have some kind of like before that he'll feel he's having diaphoresis, he'll having some kind of fear, some sweating is there. He feels that he's going to about to get that neural, he's going to get that syncope like attack. Situational syncope, you have obvious trigger, there is some cough, some micturition, something is there, that is a trigger is obviously you'll find. But orthostatic hypotension is more of sudden, like suddenly you get up, you'll after with the posture it will suddenly with posture you'll find the sudden drop in blood pressure, you'll find that there is no prior any micturition or anything like episode like that is there. So this is how, like generally patients older than 40 years, any previously 3 episodes, especially in the case of cardiac cases, you might need some cardiac device or some defibrillator or something like that, or inside based on what is the case, what is the diagnosis, you need some cardiac rehabilitation therapy, that is that sometimes structural heart is not because cardiac resynchronization therapy or defibrillator might be needed, some pacing might be needed in the case of AV blockers. So especially for older patients, more than 3 attacks might require such kind of therapy, and also with prominent cardiac inhibition, with carotid sinus syndrome also might require such kind of therapy, pacing and all. So this is a case of orthostatic hypertension where you see with changing posture you will find a drop and increase in blood pressure. So this is orthostatic hypertension, and heart rate is not significant. Generally when you stand up, no, the tachycardia should be there. It is not there in this case, but you can see the fluctuation in blood pressure with changing posture. So this is also one more case where neural mediated syncope is there. So where you can see sudden stop in blood pressure because of that, when the trigger is there, the sudden drop in blood pressure. You can see here also heart rate is also decreased. Generally heart rate should increase when there is a because of sympathization, but here there is heart rate decrease because of the excessive vagal stimulation. So you can find that drop. So because of some specific trigger, that may be carotid sinus, some cough reflex or fear or something, whatever. Neural mediated syncope is the possibility here. So these are again the possibility: cardiac syndrome, arrhythmia, generally abrupt in onset, generally palpitations may precede the symptoms. HOCM, exertional syncopes, as I told you. Structural heart disease, you will always find some AM, acute MR, some valvular disease or infiltration. You can find in the 2D echo. Mostly 2D echo can be done. In arrhythmia, generally if you are not finding in the ECG, you can do Holter monitoring. You can do Holter monitoring. Sometimes for aberrant pathways, you can even do electrophysiological studies also to find any aberrant pathways there, or that so that you can ablate that aberrant pathway. So Holter monitoring you do. Then if Holter finding also you are not finding any significant, you can go for electrophysiological studies. So for structural heart disease, you mostly go for 2D echo. And other structural is any acute aortic dissection, cardiac tamponade, pulmonary hypertension, you can get a C, you can find them, most of them in CT you can find them. And pulmonary embolism can also cause syncope-like attacks. So these are all the possibilities. So neural mediated carotid sinus massage, generally head rotation or pressure on the carotid, like shaving on the tight shaving or tight collar, these can trigger the carotid sinus. Situation brought on coughing or defecation. Vasovagal, mostly mediated by fear, heat or something. Drug induced, especially after you start some alcohol or some anti-diabetic drugs, some antihypertensives like ACRB and alpha blockers or anti-Parkinsonian drugs. These can, this like after starting some drugs like this, like anti-anginas which can cause hypotension, antidepressants, they can cause postural hypertension. These are all possible. Postural tachycardia syndrome can also, especially in the young males, this is there. I will tell about, read about POTS, I'll tell you what is postural tachycardia syndrome, read about POT and POTS, I'll tell you what about it, read about it. Primary atomic failures due to some condition like Lewy body dementia, multisystem atrophy, or multiple sclerosis, where the atomic failure is a part and parcel of those disorders, like especially synucleopathies like Lewy body dementia, Parkinson's, MSCS and all. Secondary to atomic failure can be seen, as I told you, we have seen one case of diabetes, some polyneuropathy, some amyloidosis, especially spinal injury also, uremia also can cause atomic failure. So these are all possibilities in the case of them. Volume depletion is also can cause of syncope, but in volume depletion is generally felt tachycardia, and history of acute G or some blood loss will be there. Okay, these are all the possibilities, and always when you are living in neural mediated syncope, always look out for any absence of cardiac conditions first. So especially in vagal syncope, you will find prodromal symptoms like diaphoresis, dizziness, nausea and all. Situational, you will find other cardiac abnormalities will be normal. So these are the risk stratification. So who requires hospital admission, who are can be evaluated outpatient. So any patient less than 50 years and no history of cardiovascular disease or normal ECG findings, symptoms consistent with neural mediated or orthostatic hypertension syncope generally can be discharged home. You can advise them like if younger people, most of them are neural mediated syncopes, and you can advise them proper fluid management should be done. And if you are getting some syncope, if you are feeling some symptoms like especially in vasovagal syncope, especially when they're fear, they'll have diaphoresis, sweating and nausea. You can do abdominal tensing and also crossing over your legs so that increase venous return so that it will prevent the syncope like attacks. If it's still not, you can manage it pharmacologically with fludrocortisone and all. And generally they can be managed conservatively also. But especially these people, any arrhythmia is there, you need to do Holter, ECG monitoring, Holter, 2D echo, electrophysiological studies to be done. And also any comorbid severe anemia and arterial abnormality should be corrected. Any ECG abnormality like sinus bradycardia, any QT interval prolongation or QT shortening, or sometimes Brugada syndrome can present with syncope. I will tell you what are the patterns that this will discuss about this and the ECGs. Any family history of sudden death, especially seen in the case of HOCM. HOCM can be present, have family history, so any family history of sudden death can be present. Any hypertension is there also, you need to admit and see. Any older age, any structural heart disease, these are all indication for admission. Especially in younger patient who doesn't have any significant cardiac risk factors and all vitals are normal, ECG is normal, you can send them home. Most of them are neural mediated syncopes. So this is how we evaluate. Initial evaluation, ask for history, examination and orthostatic hypertension. Any is there, treat based on the etiology what is there. It's non-syncopal. And ECG, and also get laboratory investigations. Any electrolyte abnormalities are there, how are the various parameters, routine parameters, CBP, anemia is there, anything is there. If there are, you can correct them. And just based on the suspected significant, if any suspicion is there, so based on the suspicion of the study, you generally find postural. If there is any drug that is causing postural hypertension, you generally avoid them. If it is not there, you advise them high salt diet and also proper fluid replenishment it needs to be done. It's done in pharmacological management. Neural mediated tech, you do head-up tilt testing. So head-up tilt test is one test that is used for neural mediated syncopes. Head-up tilt test can be done, so that will tell about whether neural mediated syncopes are present or not. So neural mediated syncope head-up tilt test is done, and based on the diagnosis, if the precipitating factor is there, avoid the trough, education and pharmacotherapy can be done. So no consider cardiac syncope. Generally cardiac syncope should be ruled out if the neural mediated syncope, especially in younger people. And sometimes psychogenic cause may be there. Sometimes patients, generally psychogenic patients will have, they don't have significant, they'll be conscious and all, they don't have any, and they have like no specific triggers or they do it for random reasons, and they generally recover very fast also after syncope. So these are the people, and frequent, they'll generally frequent, and they're more aware, they need more attention seeking, and also that is a possibility. And generally you can do, to rule out cardiac, you do 2D echo, Holter monitoring, electrophysiological studies to be done. So if you are suspecting cardiac syncope more and unexplained, if you are suspecting cardiac, generally stratify to low risk and high risk, like previously as I told you. Use if the patient have frequent syncope attacks, you can do Holter monitoring. If it is not infrequent, you can do implantable loop recorders. Generally we do Holter monitoring only in almost all cases. If it is high risk, the patient is elderly, structural heart disease, you are suspecting, arrhythmia is suspecting, you need to do ECG, you need to electrocardiograph, you need to do carotid sinus message, you need to electrophysiology to find aberrant pathways. Exercise stress testing also needs to be done, head-up tilt testing, all these testing need to be done, especially in elderly people who you think high risk of syncope, because they might have some underlying structural disease or some arrhythmia, some neural mediated pathway that can pose them at risk of mortality later on. That's why baseline ECG, 2D echo, electrophysiological studies, Holter monitoring, head-up tilt testing for any neural mediated syncopes, and also carotid sinus message. All needs to be done. If it is positive is there, yes. Otherwise, you can monitor them. You can keep on monitoring them. So these are the various triggers: profound standing and present orthostatic hypertension and neural mediated syncope like vasovagal. Sudden changes posture is mostly orthostatic. So supine, cardiac syncope. Supine, if you are getting supine, mostly cardiac syncope. If you are getting a syncope in supine position only, most of them are cardiac syncopes. So amnesia. So generally post syncope amnesia is present in both seizures. Seizures are mostly will have amnesia. Generally syncope will recover in few minutes. Generally eyes are open during seizures. Eyes are mostly closed during in the case of pseudo seizures or syncope like episodes. So eyes are generally open during seizure because they cannot close, muscles are not active. And fatigue, nausea, vomiting generally are suggested neural mediated syncopes. Focal neurological distress always used in neurogenic syncope like a severe transient ischemic attack. And immediate recovery is mostly seen in cardiac arrhythmia or psychogenic. Generally immediate after the arrhythmia also generally you will recover normally. So that is cardiac or psychogenic. So generally fatigue, nausea, vomiting is generally seen neural mediated syncopes. And this incontinence may be there in seizure also. Sometimes seizure is a closed mimicry of syncope. Generally seizure will be more lasting and more long. It's more long, and this syncope is more transient. And seizure will have tonic-clonic movement. Some frothing, tongue bite, urinary incontinence, and fecal incontinence. So urinary incontinence can be there in the syncope also, but fecal incontinence is very rare in the case of syncope. But urinary incontinence can be there in the case of syncope also, but fecal incontinence is very rare. But consciousness lost is generally brief, but seizure it is long, and post episode amnesia is also long in the case of recovery, is long in the case of seizures. Like muscle pains are significant in the case of seizures, but they are very less in the case of syncope. They generally recover fast. So myoclonics can be observed, especially in the case of neural mediated syncope. You can find generalized myoclonias also. So that doesn't mean that myoclonia is there. That doesn't mean the patient is having seizures. Sometimes neural mediated syncope can have myoclonic symptoms. So that can also be a possibility. Confusion is seen in the case of syncope. Prolonged syncope is generally seizure. You need to always prolonged syncopes needs to be evaluated with syncope or some metabolic or infections. Slow pulse is mostly cardiac syncope. Tongue biting is generally seizures. Tongue biting, frothing, these are all generally mostly seizure related. And any activity such as coughing, neural syncope, emotional distress, neural mediated exertion, cardiac syncope, especially anything you are getting on supine position, it is a cardiac symptom. Anything that your exertion is there, first you should cardiac, then you look for this neurological. And hand and upper extremity, subclavian steal syndrome. Like if his patient is getting syncope, like this is one patient where the patient is getting transient loss of consciousness on when he's washing things or doing to mechanical work with hands. That is because of subclavian steal syndrome. Subclavian steal syndrome can also present with syncope like attacks, because when you're using that activity with that hands more, no, because of decrease your perfusion to the brain, because perfusion will go to the hands and all. So that can present as subclavian steal syndrome, can present as syncopes. Antiarrhythmics, antihypertensives, any post-exertion neural mediated syncope. Standing for prolonged can present orthostatic hyperextension. Alcoholism, diabetes, Parkinson's can cause autonomic failure, and that can cause family history of sudden death, HOCM, heart diseases. These are all psychiatric. All these needs to be ruled out before telling it is wrong. In case of syncope, so you do basic laboratory investigations. Any you to look for any complete blood picture in the case of anemia, any heart failure is there, BNP testing, any blood loss is there. So these all needs to be done, and carotid sinus massage test should be especially done. So if the after carotid sinus massage the blood pressure decreases by more than 50, it is carotid sinus, like excessive carotid sinus stimulation only. ECG needs to be done all patients with syncope, and also echocardiography needs to be done, especially if you are suspecting structural heart diseases. Electrophysiological studies for if you have to look for any aberrant pathway or bundle branch blocks are there, especially in the case of high risk. Generally, if you are suspecting low risk, younger people, if you are suspecting high risk patients, if you have strong suspicion this is an arrhythmia or some aberrant pathway is there, then if it is recurrent also, especially if it is recurrent high risk, you need to do electrophysiological study also. Exercise testing needs to be done, especially in the case of hypertrophic cardiomyopathy, and this needs to be done with exertion. If you are finding some tachycardia or some decreased perfusion or some block, sometimes the arrhythmias can be triggered with exercise, especially Brugada can be triggered with exercise, QT prolongations may be triggered with exercise. So arrhythmias can also be done in the case of exercise testing. Head-up testing is mostly done for neural mediated syncopes and orthostatic hypertension. So this also will be helpful. Neural mediated syncopes can also help you differentiate in the syncope and with seizure also. So head-up test is one thing that can be done to look out for the neural mediated syncope. And neurological testing for any suspected seizures or CVI, you get imaging if you are finding any focal deficit, and if this episode is prolonged or significant fecal incontinence is there, you need to get a EEG also. Orthostatic hypertension needs to be evaluated for checking postural blood pressure variation. Psychiatric evaluation if you are suspecting psychogenic. So these are all possibilities. Like all of these are possibilities, especially if you are an younger. So especially in the case if it is a patient is younger, always most common cause is neural mediated syncopes. Generally, if they have some amount of fear, anxiety, something is there, they have some diaphoretic symptom, they have vasovagal syncope, some situation related syncope like with cough or micturition or some any instrumentation, the situational syncope is there. Orthostatic hypertension, especially in the case of patient who are recently started on some drugs that can cause postural hypertension, or some underlying diseases there, some multi-system atrophy or Parkinson's or Lewy body dementia, that can be a possibility. And also especially who are long-standing elderly diabetic neuropathies there, some amyloidosis there, or some spinal injuries there, that can also cause autonomic failure at postural hypertension is a possibility. Then always younger patient who is having exertional syncope or patient present syncope is present on supine position, you always look for cardiac causes. You can get an ECG, Holter monitoring, especially if it has higher risk people who are having recurrent episodes are there, you need to get a electrophysiological study also. And exercise testing can also be done in the case to trigger any arrhythmia or any HOCM like episode. So exercise testing, tolerance test can also be done. So all of these are the possibilities. So younger people neural is more common, elderly people orthostatic and cardiac are more common. So any patient less than 50 years, generally they can be manage OP base more than 50 years. If they have significant cardiac or other symptoms, you need to admit them and evaluate. Hypertension is that you need to, if the recurrent as well, only to admit and evaluate and treat properly. Generally, neural and orthostatic are generally managed conservatively with some amount of fluid management, some exercise like abdominal tensing or crossing over legs, or you can advise them fluttercortisone if it is needed, or midodrain. And if there is offending agent, you need to stop that also and avoid the trigger, whatever trigger is there, that you need to avoid. In the case of cardiac, based on the cause, if it is structural heart disease, there you can, if there is some ischemic heart disease, some cardiac reconnaissance therapy or assist device can be put. If it is blocks, you need to do pacing. If there is a arrhythmia, ventricular VF or something, you need to put defibrillator. Based on the cause, you need to. So always look for all these causes before you label it as a. This is how you evaluate a case of syncope.